Hello everyone, myself Dr. Reshma Kiran. I am the STEP GHA NEET PG faculty for the subject of biochemistry. So as the dates for the NEET PG exams are nearing, one approach everybody should be having is to prioritize on the previous year questions, or what is PYQs, from the high yield topics. So today's sessions, I'll be dealing with such questions, about 20 of them, and you could understand how to work on these questions. These are the questions which have been repeated from the last 5 years. Okay, so without further ado, let's get started. So here we have the question number 1. A child presents with pedal edema, cheilosis and cardiomegaly. Which vitamin deficiency is most likely causing these symptoms? So let me just highlight the signs or the clinical manifestations here. The first is pedal edema, second is cheilosis, third is cardiomegaly. Out of these two, I would want to pick up these two clinical manifestations, that is pedal edema and cardiomegaly. What is this telling us? So pedal edema, as we know, is fluid in the interstitial spaces or in the tissue spaces. Cardiomegaly is enlargement of the heart. So which is that vitamin which is deficient and is going to give us this particular feature? The option is option number D, that is thiamine deficiency. Alright, so let me just write the names of the corresponding vitamins. So pyridoxine is B6, niacin is B3, riboflavin is B2 and thiamine is B1. So we understand all these 4 vitamins belong to the B complex group. So this particular condition, do we have a name given for it? Yes, we call it as beriberi, right? So beriberi is the deficiency disorder of the vitamin B1 or thiamine. Now, what are the types of beriberi? We have wet beriberi, we have dry beriberi, we have the infantile beriberi, we also have the cerebral beriberi. Alright. Now, what is wet beriberi? The name is telling something to do with water. So, in this case, what we are seeing is edema, that is fluid or water accumulation in the tissue spaces. So, which kind of beriberi is this child having? It is the wet beriberi. What is dry beriberi? Dry beriberi would deal with the central nervous system. So, it would mainly affect the nerves. Infantile beriberi is seen in babies born to mothers who are deficient with thiamine. Cerebral beriberi is to do mainly, it is seen in a group of people, mainly the chronic alcoholics. We see the cerebral beriberi. But in this condition, what is the child having? The child is having wet beriberi. And what is the vitamin that is deficient? It is thiamine or B1. Now, why are we ruling out the rest of the B complex vitamins or the options what we have here? So, the first one here, that is the pyridoxine. What is the deficiency of pyridoxine? There is no particular name given, but most of the times it will cause peripheral neuropathy. So, you can remember the alphabet P, pyridoxine P will cause peripheral neuropathy. Niacin deficiency, yes, we have a name given for the deficient disorder. It is pellagra, right? And riboflavin will present mainly with glossitis and cheilosis. So, cheilosis is present in this child, yes, but apart from that, 2 major symptoms or the signs what the child is having is pedal edema and cardiomegaly. So, we have to go for it. So, just because we see cheilosis, we cannot assume it is riboflavin deficiency. We have to concentrate on the main 2 clinical manifestations, that is pedal edema and cardiomegaly. So, this is wet beriberi and the correct option is option number D, thiamine deficiency. Alright. Now, let's move on to question number 2. What do we have here? A 2-year-old child presents with developmental delay, inability to walk, bone pain, and a cherry red spot on the fundoscopic examination. Now, there's a negative clinical feature that is given, that is, there is no organomegaly. That would mean there is no enlargement generally of the liver and the spleen. So, what is the most likely diagnosis? What are the options we have here? We have Hurler disease, we have Niemann-Pick disease, we have Tay-Sachs disease, and we have the Gaucher's disease. So, this child, what are the key feature we have to check? So, I have circled on that, that is the cherry red spot. Okay. So, cherry red spot, which condition do we see? We see it in the Tay-Sachs disease. Now, another condition can also give rise to cherry red spot in the given option, that is Niemann-Pick disease. So, why are we opting for Tay-Sachs and not Niemann-Pick disease in this condition is because of this key negative clinical feature, that there is no organomegaly. If there was to be an organomegaly, then it would go more in favor of Niemann-Pick disease. So, cherry red spot, no organomegaly, we have to say it as Tay-Sachs disease. Now, what is Tay-Sachs disease? Tay-Sachs disease belong to the group of disorder of lysosomal storage disorder, or LSD. What is the enzyme deficient here? It is the hexosaminidase B. Alright, the enzyme is hexosaminidase. So, you can remember this as Sachs. It sounds like 6. 6 is hexa. Alright, so Tay-Sachs disease is hexosaminidase B. What is accumulated here? It would be the GM2 ganglioside. Alright, GM2 ganglioside. This is the enzyme defect. This is the accumulated compound, GM2 ganglioside. So, the child presents with developmental delay, inability to walk, and cherry red spot on the eye examination or the fundoscopic examination. There will not be any kind of organomegaly. So, we can confirm the diagnosis here as the Tay-Sachs disease. What about the other options? So, let's have a quick look at the other options given here. So, we have the Hurler's disease. Hurler's disease, yes, what is it? It is mainly a kind of mucopolysaccharidosis. Do we have an eye sign here? Yes, we have corneal clouding. Okay, corneal clouding. So, the eye or the cornea becomes more opaque here. But yes, there is no cherry red spot. So, we can rule out Hurler disease. Niemann-Pick disease, it is again a lysosomal storage disorder caused by the deficiency of the enzyme sphingomyelinase. Is there cherry red spot here? Yes, there is cherry red spot with hepatosplenomegaly. That's why we are ruling out. So, we know this is our correct option. Gaucher's disease, no, because it is mainly to do with glucocerebrosidase deficiency, and there is hepatosplenomegaly would be the main feature along with the microscopic crumpled tissue appearance. That's why we are ruling out Gaucher's disease here. No eye sign here. So, Tay-Sachs disease, enzyme defect is hexosaminidase B, accumulated compound is GM2 ganglioside. With that, let's move on to the next scenario. Which of the following clotting factors requires gamma-glutamyl carboxylase for the activation? So, here is a list of different factors. Option A is factor 2, 7, 9 and 11. Option B is 2, 8, 9 and 10. Option C is 2, 7, 9, 10. Option D is 2, 7, 9 and 11. What is the correct option here? The correct option is option number C. That is factors 2, 7, 9 and 10. Okay, 2, 7, 9 and 10. So, clotting factors, where are they produced? The clotting factors are produced in the liver. They are generally inactive. To activate it, we need an enzyme gamma-glutamyl carboxylase, which is helped by the vitamin K, fat soluble vitamin K. So this is called as the vitamin K cycle or the gamma carboxylation cycle. So there will be a carboxyl group that will be added to the glutamic acid. That's why it is called as glutamyl carboxylase. So when the glutamic acid receives this carboxyl group, this is a kind of post-translational modification. Now, what is post-translational modification? We know that translation is the synthesis of proteins. Clotting factors are proteins. Now, once produced to activate it, there has to be some kind of modification. In this case, we are going to add a group, that is the carboxyl group. So, vitamin K plays a major role in this kind of carboxylation. So, gamma-glutamyl carboxylation, and what are the factors that are activated through this vitamin K cycle are factor number 2, 7, 9 and 10. Alright. Next, let's go to case number 4. A young boy presents with recurrent episodes of muscle cramps. Alright, I'll underline that, muscle cramps and fatigue during physical activity. Yes, which resolves with rest. He exhibits hypoglycemia, decreased serum lactate and the glucose levels post-exercise. Based on these findings, which of the following glycogen storage disorder is most likely? Alright, so we know the hint is there in the question itself that this is a disorder of the glycogen storage. Okay, now what is the chief complaint? The chief complaint is muscle cramp. Now, what is glycogen? Glycogen is the storage form of a carbohydrate. So, glycogen will break down to glucose 6-phosphate and to glucose. So, this step we see in the muscle, this step we see in the liver. Alright. So, we know glycogen is stored in two main organs. One is the liver, one is the muscle. What is the purpose of the liver glycogen? The purpose of the liver glycogen is to maintain the blood glucose homeostasis. What is the role of the muscle glycogen? Is to provide ATPs to the muscle. So, it stops at glucose 6-phosphate which enters the glycolysis pathway. Now, what is happening in this child is there is muscle cramps during physical activity. So, we have to understand here that the glycogen is not getting converted to glucose 6-phosphate. Hence, there is no glycolysis. The child is not getting that ATPs for the muscle. That's why he is having the cramps and fatigue. So, what is the enzyme deficient here? The enzyme deficient would be muscle glycogen phosphorylase. Muscle glycogen phosphorylase. Now, which of the options have this enzyme deficient? Very easy to remember because you remember the letter M. So, which of these four options are having the letter M? Yes, that is the option number A, McArdle's disease. So, McArdle's disease is due to the deficiency of the enzyme muscle glycogen phosphorylase. So, glycogen is not broken down to glucose 6-phosphate, no glycolysis, no ATP, and the child is going to have those muscle cramps. Now, there is a history here which is telling us that during rest, the symptoms are better. Why does that happen? Is during rest, the source of energy would shift to fatty acid. So, fatty acids go in for oxidation and hence the ATPs are derived. So, physical activity that is not going to happen because it's a very fast process. So, the first requirement generally would be glucose, but that is not happening in this particular scenario. That's why the case is McArdle's disease. The deficient enzyme is muscle glycogen phosphorylase. Why not the other option? Yes, all four belong to the group of glycogen storage disorder. HERS, again, easy to remember, hepatic HE. So, you can remember hepatic glycogen phosphorylase. Alright, I told you it's in the liver and in the muscle. So, Her's disease is hepatic glycogen phosphorylase. Cory's disease is to do with the debranching enzyme. Okay, debranching enzyme. So, remember CD, then A and B, A, B, C, D. So, Anderson's disease, the enzyme defect is the branching enzyme. So, none of these are to do with the muscle glycogen metabolism. So, the correct option should remain as McArdle disease. So, this is how the muscle stores the glycogen in case if the enzyme is deficient. This is how it is going to look under the microscope. Okay. Moving on to question number 5, we have a chronic alcoholic patient who presents with ataxia, confusion and painful eye movements. Which of the following vitamin deficiency is most likely responsible for these symptoms? So, we have the patient who is a chronic alcoholic. So, we know chronic alcoholism has a problem with the vitamin metabolism because it is going to hamper with the absorption of the vitamins. So, generally alcoholics will have multiple vitamin deficiency. But let's see what is he having in this particular case. You have ataxia, that is imbalance or a problem in the gait, confusion or disorientation, painful eye movements. Okay, so 3 cardinal symptoms: ataxia, confusion, painful eye symptoms. I'll give you a mnemonic here: COATRACK. How do we read this? Coat rack. Okay, coat rack. Co stands for confusion. Yes, this is there in this patient. O stands for ophthalmoplegia. Ophthalmoplegia. What is ophthalmoplegia? Ophthalmoplegia is the paralysis of the eye muscle. Does this patient have it? Yes, there are painful eye movements. So, yes, second symptom is also there. What is A stand for? Ataxia. Does this patient have? Yes. So, COA, confusion, ophthalmoplegia, ataxia is present in this patient. So, what should be T here? The T should be thiamine. Yes, the T should be thiamine. So, we have got it through the mnemonic itself, the answer. So, which one of this it is? Vitamin D, vitamin C, vitamin A, vitamin B. So, what is thiamine? Thiamine is vitamin B. So, B1 to be specific. So, the correct answer is vitamin D deficiency, that is our option number D. Now, I told you another mnemonic, RAC. RAC stands for retrograde amnesia. What is retrograde amnesia? Person starts forgetting about the past events. Next is anterograde amnesia. A stands for anterograde amnesia. Anterograde amnesia, he is not able to form new memories. C. Alright, C again would stand for confabulations. What is confabulation is? He starts making up his own stories. Okay, so what is K? K is the name of this disorder. We call it as Korsakoff syndrome. Alright, Korsakoff syndrome. So, what is this? This particular scenario would be called as Wernicke's encephalopathy. Wernicke's encephalopathy. Okay, so this would be the initial stage. If not treated, the person will go in for more like a chronic Korsakoff psychosis or Korsakoff syndrome. Yes, so both are seen in alcoholics, both are due to thiamine deficiency. So, what is this person having? Is it Korsakoff syndrome or Wernicke's encephalopathy? You have to see the mnemonic coat rack. So, it fits in to the diagnosis of Wernicke's encephalopathy, thiamine deficiency in an chronic alcoholic patient. So, which is the vitamin deficient? It is vitamin B. What about the other options? Yes, other options not possible because vitamin D deficiency we know causes rickets, vitamin C deficiency causes scurvy, vitamin A deficiency would cause more of the eye or vision problems. Okay, So yes, that's the correct answer. Now, let's go on to the case number 6, or question number 6. A patient from the Mediterranean region develops malaria and is treated with an anti-malarial drug. Now, what is the name of the anti-malarial drug? It is called as primaquine. Shortly after, he experiences hemolytic anemia, a deficiency in an enzyme of which metabolic pathway is most likely responsible for this condition. So, we have the options of metabolic pathways here. One is glycolysis, one is gluconeogenesis, third is hexose monophosphate pathway or HMP shunt pathway, third is Lubering-Rappaport pathway. What is common to all the 4 pathways? All the 4 pathways belong to which metabolism? They belong to the carbohydrate metabolism. Now, the patient is a malaria patient who has been taking primaquine. So, once he's taken primaquine, he's developed hemolytic anemia. What do we call such kind of hemolytic anemia? We call it as a drug-induced hemolytic anemia. Alright, drug-induced hemolytic anemia. Otherwise, he would not have got this hemolytic anemia. Because he's taking this drug, he's getting this anemia. What is the correct option? The correct option is option number C. That is hexose monophosphate pathway. Why do we think it is this? Let us just go through the pathway first. So, what do we see? This is the HMP shunt pathway or the hexose monophosphate pathway. So, which is the enzyme we are targeting here is this, right? That is our glucose 6-phosphate dehydrogenase deficiency. Alright, what is the role of this particular enzyme is it is going to give us a very important compound, that is NADPH. Now, NADPH is important because it will maintain the glutathione in the reduced state. Okay, it maintains the glutathione in the reduced state. Which part? It is mainly in the red blood cells. So, glutathione is an antioxidant. Okay, it is an antioxidant. What is the role of an antioxidant? It prevents the accumulation of free radicals. Now, primaquine is a drug when given produces free radicals inside the RBC. Why should it produce? So that it can kill the malarial parasites. But when the buildup of the free radicals or peroxides increase, there is no glutathione to counter it because the person is deficient in this enzyme glucose 6-phosphate dehydrogenase. So, if that is deficient, NADPH is also deficient. Glutathione is deficient, no antioxidant would be there to counter the accumulated free radicals post primaquine treatment. So, what is going to happen in this patient? He is going to develop drug-induced hemolytic anemia because RBC cannot maintain its membrane and it goes in for rupture or lysis. So, does every patient who is on primaquine develop this anemia? No. Only people who are deficient with this enzyme G6PD. Now, they have given a region, okay, very common in this region, Mediterranean region. Yes, the individuals who are from that particular region have this kind of enzyme deficiency. So, what is the enzyme deficiency? Yes, it is G6PD. And which pathway does it belong to? It belongs to the hexose monophosphate pathway. Alright, so we have got our correct option. Why not the other options? Yes, because glycolysis, does it give rise to any kind of hemolytic anemia? It does, but that is due to the enzyme defect pyruvate kinase. It is nothing to do with drug-induced hemolytic anemia. Gluconeogenesis, no, because it's a pathway which is going to give us glucose. So, there is no NADPH which is formed. What about Lubering-Rappaport pathway? No, because it's a pathway which is going to give us 2,3-BPG inside the RBC, which is helping us in unloading the oxygen into the tissues. So it's nothing to do with hemolytic anemia. So we can safely say the answer for this is HMP pathway. All right. So let's move on to the next question. Question number 7. Which of the following molecules facilitates the transport of long chain fatty acids across the inner mitochondrial membrane for beta oxidation? So we need a transporter. The question is a transporter which is carrying the long chain fatty acids. Maybe I'll give you an example. It could be a 16 carbon palmitic acid, okay, a long chain fatty acid across the inner mitochondrial membrane. So what do we understand here? The fatty acid is in the cytoplasm. Where is the beta oxidation taking place? Beta oxidation is taking place inside the mitochondria. So we know the mitochondrial membrane is a semi-permeable membrane. Not all compounds can move freely. So the compounds which cannot move freely needs a transport system or a shuttle system to take and drop into the mitochondria. So which one is it? Here the correct option is carnitine. The correct option is carnitine, which will act as a shuttle system from cytoplasm to mitochondria. So if you just look at the diagram, we see here the carnitine will take up the acyl-CoA, long chain acyl-CoA, and it becomes long chain acyl-carnitine, and the long chain acyl-carnitine can then move into the matrix of the mitochondria, and the acyl-CoA will be regenerated. What is acyl-CoA? It is a fatty acid with the CoA. So this acyl-CoA can then be subjected to beta oxidation. So look at carnitine. Carnitine will take up the long acyl-CoA and convert itself into acyl-carnitine. It enters into the mitochondria and there it will release that long acyl-CoA. So this enzyme is known as CPT1, which is carnitine palmitoyl transferase 1. Alright, carnitine palmitoyl transferase 1. Once inside the mitochondria, we have another type of this carnitine, which is CPT2. What does that stand for? Carnitine palmitoyl transferase 2. Okay, so let's look at the options again. Yes, carnitine is the transporter for acyl-CoA from cytosol into the mitochondrial matrix. What about the other options then? Acyl carrier protein is not in oxidation but synthesis of fatty acid. Okay, it is important in the synthesis of fatty acids. What about this? L-cat, lecithin cholesterol acyl transferase. Nothing to do with fatty acid metabolism, it is to do with the cholesterol or the reverse cholesterol transport. So we are ruling out that. Carnitine and albumin, yes, partially correct, it is carnitine, but then the option is also having albumin. Albumin will only carry the free fatty acids in the blood and will not help in the transport. Okay, so the correct answer is option number B. Moving on to the next question. What is the term used for a single nucleotide mutation that introduces a premature termination codon leading to a truncated protein synthesis? Okay, we have a question from genetics here now. So, which chapter? The mutation, alright. So, a single nucleotide mutation produces or introduces a premature termination codon leading to truncated protein synthesis. So, we understand here there is two processes we are talking about. One is transcription. Why we are talking about transcription? Because there is a mention of the word codon. Codon is present in the mRNA, alright. And then there is another process, that is translation, that is a synthesis of proteins. So, what has happened here is a mutation has occurred, one single nucleotide mutation has occurred, and that has caused a formation of a terminator codon which has caused a led to a protein which is truncated. Truncated would mean a faulty protein or a disabled protein. Okay, truncated protein synthesis. So what is the correct option here? So the question they are asking is, what is the mutation that has occurred due to this single nucleotide chain? So the correct answer here would be the nonsense mutation. Yes, so what do we mean by nonsense mutation? Is when the mRNA is being read, a stop codon has come into picture. A stop codon has come into picture. Name the stop codons. We have 3: UAG, UAA, UGA. That's you are gone, you are away, you go away. What does that mean? That means you have to stop the transcription, or the translational process has to be stopped over here. So what does it happen? It is a premature termination. A protein was supposed to be synthesized. So for example, the codon would have been AAG, and instead of A, there is a mutation at this point. So instead of A U has come into place, UAG. So this cannot code for any amino acid. It cannot code for any amino acid. So the protein synthesis halts over there, and we get a protein, but that protein is of no use. So a disabled protein. So that will cause a major change in the protein synthesis. So this kind of mutation, when a stop codon has come due to a mutational process, we call it as nonsense mutation. So you can remember, stop the nonsense. That means stop is the codon and the nonsense is the mutation. Stop the nonsense could be the, you can remember that sentence to remember the mutation in this particular condition. Okay. So why not the other option? Yes, missense mutation, what will it cause? It will not prematurely stop a protein synthesis. Protein synthesis would be there, but a different kind of protein would be formed. So there is no premature stop because there is no stop codon that is being encountered here. What about stop mutation? There is no such word as stop mutation. The word is stop codon, alright. So the option itself is wrong here. Silent mutation, single nucleotide change is seen, but it is not going to cause any effect on the protein synthesis. Okay, so the mutation, even if it is occurred, protein synthesis is not affected, or it is not at least going to give a remarkable change. So that silent mutation is not because we are getting a truncated protein. So truncated protein, premature termination, remember it is nonsense mutation. Right, let's go on to the next question. We have again a lot of questions do come from the vitamins chapter. So this becomes a very important or a high yield topic for the preparation. Yes, so we have a patient who has undergone gastrectomy. Okay, why has he undergone gastrectomy? Because of the CA, gastric adenocarcinoma. Now, which of the following vitamins must be supplemented post-operatively to prevent complications related to malabsorption? Now, when we look at the options, we have vitamin B12, B1, vitamin A and vitamin D. So, normally when we see the word malabsorption, we think it to be the ADENK, okay, because they are commonly associated with fat malabsorption. But is this the case here? No. We have to think that the person has undergone gastrectomy, removal of the stomach. So, which of these vitamins in the digestion process or the absorption process has the role of the stomach? So, the correct answer is option A, that is vitamin B12. And what is the reason is because of this. What is this? This is the intrinsic factor of Castle, intrinsic factor of Castle, which is produced by the parietal cells. So, B12 always needs intrinsic factor for its absorption down the intestine. So, this is a must. If there is no intrinsic factor, vitamin B12 cannot be absorbed. So, this patient has undergone gastrectomy. So, when the stomach is removed, there is no question of parietal cells producing intrinsic factor. So, this has to be supplemented post-operatively to prevent the complication. So, the correct answer is vitamin B12. So, if we want to look a little more on that, vitamin B12 absorption and transport, yes, we have in the saliva what is called as haptocorin. B12 and haptocorin from the mouth, okay, from the diet itself we take this. So, B12 will be called as the extrinsic factor, okay, because we are taking it in the diet. Now, when it comes down, the pepsin and the trypsin, the pancreatic enzymes will break it, and the parietal stomachs will secrete, the parietal cells of the stomach will secrete the intrinsic factor. B12 intrinsic factor forms a complex, moves down the intestine through the duodenum, jejunum, and finally, when it has reached the ileum, the B12 gets detached from the intrinsic factor and gets absorbed, okay. So, remember B12 is absorbed in the ileum, but for that it needs the intrinsic factor right up in the stomach. So, if there is no stomach or in case of gastrectomy, there is no intrinsic factor, hence B12 cannot be absorbed, okay. From there it will be taken by the protein transcobalamin into the liver where it gets stored, and it is released whenever the body needs it. So, the correct option here for this case, remember gastrectomy, vitamin which is deficient would be vitamin B12. B1, A and D, yes, we can rule out because A and D is generally to do with fat malabsorption. All right. Next, let's move on to option number 10. Okay. Question number 10. Yeah. A patient presents to the emergency department with severe abdominal pain. Okay. There is nausea and vomiting. Laboratory results reveal serum triglyceride level very high, more than 2000 milligram per deciliter. Which of the apolipoprotein deficiencies is most likely contributing to this patient's condition? Okay, so what is this patient having? Severe abdominal pain, nausea, vomiting. Many causes are there for severe abdominal pain, nausea and vomiting, and one thing we can think of, okay, let's keep it in mind, maybe this person is having pancreatitis, okay. Now, we do the serum triglyceride level which is crossed 2000. Normal TG level is less than 150 milligram per deciliter. So, it's about more than 10 times increase of the TG level. A massive TG increase, which of the following apolipoprotein is likely to contribute to this deficient or the patient's condition? So, this would be a familial or a Fredrickson's classification. When you think of it, would be the type 1 hyperlipoproteinemia, okay, hyperlipoproteinemia type 1. What is the enzyme deficient? Lipoprotein lipase, LPL, lipoprotein lipase. But we have in the options, we do not have the enzyme here. They have asked for which is the apolipoprotein. So, lipoproteins means lipids plus proteins. The protein part would be called as the apoprotein. So, which is that apoprotein? So, you will have to remember it is ApoC-II because this is a cofactor for the LPL deficiency. So, type 1 can be seen in two things. One, directly when there is a lipoprotein lipase deficiency. Second, when the apoprotein, that is ApoC-II, Why? Because ApoC-II is acting as a cofactor of this enzyme lipoprotein lipase. So, any of these two, either the enzyme is deficient or the apoprotein is deficient, we can see type 1 hyperlipoproteinemia. And how do we know it? Massive triglyceride production more than 2000. So, when we see the plasma or the serum of the person, it will be absolutely creamy or white. So, naked eye also we can check this seeing the plasma of the person, and in the eye there could be lipemia retinalis or there could be eruptive xanthomas. They all club together and they form the type 1 hyperlipoproteinemia. So, here when coming back to our question, what is the correct answer? The correct answer is, yes, it will be the apolipoprotein C2, okay, because it is a cofactor of LPL. Deficiency will cause type 1 hyperlipoproteinemia, which causes massive TG increase. Why pancreatitis in this person is because lipoprotein lipase should break down the triglycerides, right? So, when that is not there, the fatty acids can cause direct damage to the acinar cells of the pancreas, causing pancreatitis. Why not ApoB48? It is to do with the VLDL, okay, or the mainly the chylomicrons, okay, the chylomicrons. B100, 100 you remember it is LDL. B100 is the apoprotein of LDL. No, we are not concerned with this because we are thinking of direct triglycerides or chylomicrons. Apolipoprotein A1, A1 should be the best lipoprotein, which is the best lipoprotein, the good lipoprotein, that is the HDL. So, A1 the best, that is HDL, that is the apoprotein of HDL. So, definitely ruled out in this particular scenario. So, high TG, pancreatitis, apoprotein concerned is apoprotein C2. Okay, let's move on to the next. A 12-year-old boy presents with intellectual disability, self-mutilation, that is he is harming himself by constant lip biting, fingernail abrasions, increased serum uric acid levels. What is the most likely diagnosis? The answer is very direct here. Is it Hurler's or Neschnehan's, Hunter's or von Gerg syndrome? Self-mutilation is classic of the disease Leschnyhan's disease, alright, the Leschnyhan's disease, an X-linked recessive disorder, Leschnyhan's disease. Which pathway we encounter this disease is the purine salvage pathway. What is salvage? Is to save the extra purines which have been constantly degrading. The body collects all of it and forms new purine. So, purine salvage pathway. What is the enzyme of this pathway? HGPRTase, that stands for hypoxanthine guanine phosphoribosyl transferase, okay, hypoxanthine guanine phosphoribosyl transferase. So, HGPRTase deficiency will cause Leschnyhan disease. They will also have serum uric acid levels because excess purines will break into uric acid, and here the hypoxanthine goes in directly for the formation of xanthine to uric acid. So, that is why we see hyperuricemia in Leschnyhan's disease. So, how will we know it? Intellectual disability plus self-mutilation. You have to remember that this is Leschnyhan disease. Why not? We are taking other options here. Yes, Hurler syndrome, again it is mucopolysaccharidosis, no self-mutilation. Hunter's disease, again mucopolysaccharidosis, again is no self-mutilation. Von Gerg's disease is a separate disorder, that is the glycogen storage disorder. So, all the three do not have the cardinal feature of self-mutilation. So, easily we can think the answer is Leschnyhan's disease. Alright, so coming to question number 12. What do we have here? A young patient presents with ectopia lentis. What is ectopia lentis? The lens has been displaced. Displaced lens, elevated serum homocysteine levels, but no evidence of megaloblastic anemia. Which vitamin supplementation is most likely to benefit this patient? Ectopia lentis, elevated serum homocysteine level. Can we name the condition? Yes, it is homocystinuria. So, there are many causes of homocystinuria. It could be B12 deficiency, or classical one where the enzyme is deficient, that is cystathionine beta synthase. Alright. So, is B12 deficiency given in the following options? No, it is not given, and also we can rule out B12 deficiency because there is no evidence of megaloblastic anemia. We know that B12 deficiency should give us megaloblastic anemia in peripheral smear. So, that is missing in this case, but which other vitamins should we think of here? Is it thiamine, pyridoxine, biotin, or riboflavin? So, let's take the correct answer, that is pyridoxine. Why are we thinking as pyridoxine? Because this enzyme cystathionine beta synthase requires the coenzyme PLP. What is PLP? PLP stands for pyridoxal phosphate. What is this a coenzyme of? Pyridoxal phosphate is the coenzyme of pyridoxine. Alright. So, here if you see here, we see one, vitamin B12 is important. A second, we know B6 is important for the vitamin, for the enzyme cystathionine beta synthase. So, when this B6 is not enough, this enzyme cannot function normally, homocysteine starts elevating, causing homocystinuria. Alright. Homocystinuria will be characterized by long limbs, ectopia lentis, Charlie Chaplin gait, and yes, in severe forms can lead on to early cardiovascular deaths. Okay. So, which vitamin would we want to supplement? Is it B12 or B6 in this patient? Remember, it is pyridoxine because the enzyme cystathionine beta synthase CBS requires B6, that is PLP, pyridoxal phosphate. Option number B is correct over here. Alright, let us move on to the next case or question. A young female presents to the emergency department after ingesting 10 tablets of phenobarbital. Okay, phenobarbital. Which of the following components of electron transport chain is inhibited by this drug? So, it could be a case of poisoning of phenobarbital. So, phenobarbital, which is a drug, will inhibit which of the complexes? So, we know there are 4 complexes here. There is complex number 1, complex 2, complex 3, 4. So, main 4 complexes of the ETC. Alright. So, every complex can be inhibited by drugs. What happens by these drugs or toxins when they inhibit the complexes is the electron transport will be halted, and when the electron transport is halted, what is important in ETC is the production of ATP. So, ATP production is through the electron transport chain. For it to occur, we need to have a smooth transfer of electrons. So, if there are drugs which can inhibit individual of these 4 complexes, that can halt the ATP production. So, phenobarbital is going to target which of these 4 complexes? It is this, that is complex 1. Complex 1 to Q. What does that mean? From complex 1, electrons move into the mobile carrier coenzyme Q. So, phenobarbital will inhibit this. So, we can say it is a complex 1 inhibitor, complex 1 to Q. Succinate to iron? No, the inhibitor commonly is malonate. Complex 1 to 2, there is no such movement at all. 1 to 2 is not a movement of electrons. Electrons do not take the path. Electrons will take from 1, 3, 4 or 2, 3, 4 depending on whether it is NADH or if it is FADH2. So, the option itself is wrong here, that is complex 1 to 2, no movement of electrons. Complex 1 to Q, this is the correct answer. Complex 4, we have a famous potent inhibitor, that is cyanide. So, cyanide is complex 4 inhibitor and complex 3 inhibitor is antimycin. Complex 1, it is mainly phenobarbital or also one more, that is rotenone or the fish poison. So, phenobarbital, remember, it is complex 1 inhibitor. So, you can safely tell the option here is option number C from the complex 1 to Q. Okay, let's move on to the next question. Yeah, here we have a 32-year-old woman who presents with erythematous scaly rashes on the forearms, neck and face. So, what we understand here is, let me write over here, these are the sun exposed areas, right, along with loose stools. So, I would write here it as diarrhea, and memory problems, I would want to write it as dementia. Okay. So, I would write here as dermatitis because of the skin rashes. There is loose stools, I would call it diarrhea, memory problems, dementia. So, we have 3 D's over here. So, we know the 3 D's is pellagra. Let me stop it here. Let me continue with the case. She recently shifted to a corn-based diet due to financial constraints. Yes, laboratory investigations reveal normal electrolyte levels. Which of the following interventions is most likely to alleviate her symptoms? That means, which would give her relief from these symptoms? Let us look into the option: oral nicotinamide supplementation, intravenous thiamine administration, high dose vitamin C supplementation, or discontinuation of the corn based diet. Yes, we know the person is on corn based diet, but she is already presenting with the symptoms. So, what would be the correct option? Correct option is A, oral nicotinamide supplementation. Why have we selected this? Is because we already got from the history 3 Ds: dermatitis, diarrhea, dementia. We call it as pellagra, and we know pellagra is due to the niacin deficiency. Yes, corn based, because in corn it is the niacin is in the bound form, or there is a lack of tryptophan which will not give us the niacin. So, the patient is deficient in niacin. So, we give the supplementation nicotinamide. Nicotinamide is nothing but the amide form or the active form of niacin. So, do not get confused with the word nicotinamide. It is nothing but niacin in its amide form or the active form. So, when we give the oral nicotinamide supplementation, the person's symptoms are relieved. Okay. Now, here given here, normal electrolyte levels, it is just to deviate from this. Okay, normal electrolyte levels, because the person is having diarrhea, and we know normally in diarrhea what is going to happen is electrolyte imbalance is seen. But here it is not seen because this diarrhea is not very severe, or rather the diarrhea is more of a chronic diarrhea. It is there for a longer time. So, we cannot appreciate the electrolyte imbalance over here. Alright. Now, why are we not taking the other options? Intravenous thiamine administration, thiamine deficiency causes beriberi and not pellagra. High dose vitamin supplementation, no, this is not scurvy, this is pellagra. Discontinuation of the corn based diet, yes, this could help, but this would have helped in the initial stages, but she has already developed the symptoms. So, discontinuation of the corn based diet, though might be partly correct, it is not a perfectly correct answer here. So, the correct answer is oral nicotinamide supplementation. Okay. So, this is how the rashes appear, mainly in the sun exposed areas, yes. And what do we call this particular necklace? We would refer it as the Castle's necklace of Pellagra. Okay. So let's move on to another electron transport chain based question. A mother found her child experiencing severe breathing difficulty. After coming into contact with rotenone, despite emergency medical intervention, the child tragically passed away. Rotenone is known to inhibit which enzyme, disrupting cellular respiration and likely contributing to her death. So, rotenone, we'll remember it to be a fish poison. Also, it is a insecticide, all right. It is an insecticide. So, remember rotenone should inhibit complex number 1. Rotenone, phenobarbital, or sedatives, they're all complex 1 inhibitor, okay. So, why has there been a death? Because rotenone in severe amounts will inhibit the electron transport. When there is no electron transport, cellular respiration halts and there is no ATP. The lack of ATP can cause death. That's the reason of death in this child. So, remember rotenone is complex 1 inhibitor. So, here they have not given you the direct names, whether it is complex 1, 2, 3, 4. What they have given is the names of this complex. So, let me write here, cytochrome C reductase is nothing but complex number 3. Succinate dehydrogenase is complex number 2. NADHQ oxidoreductase is complex number 1. Cytochrome oxidase is complex number 4. These are the names or the enzymes related to the complex. So, sometimes you will not be asked directly whether it's complex 1, 2, 3, 4. It would be these names. So, you have to remember these names as well. So, complex 1 is called as NADH. Why is it called as NADH? Because NADH will give the electrons to complex number 1. So, the name is NADHQ oxidoreductase, and complex 2 is called as succinate dehydrogenase because succinate will be converted to fumarate. So, this is succinate dehydrogenase. So, it's complex number 2 over here. Then we have cytochrome C reductase because cytochrome C is in close proximity to complex number 3. Complex 4 would be the cytochrome oxidase. So, you have to remember these 4 names. So, what is the correct option here? I already mentioned to you rotenone inhibits complex number 1. So, I have mentioned to you what are the names of these enzymes. So, which is complex number 1? It is the NADHQ oxidoreductase. This is the correct answer. So, complex 1 is also called as NADHQ oxidoreductase. So, rotenone inhibits this particular complex. Let's move on to the question number 16. Which of the following is the primary function of proteasome? Okay. So, let me just show you the diagram of a proteasome. So, this is a proteasome. So, you can see like a barrel. Okay, you compare it to with an incinerator. What does an incinerator do? You put something and it burns. So, here what is happening is the proteins which are faulty or which are misfolded or which has finished its function will enter here and will be degraded. It will form peptides. The peptides will give us the amino acids. The amino acids will be taken to form new proteins. Okay. So, what is this proteasome acting as? Proteasomes will take the targeted inactive proteins or misfolded or faulty proteins, are the proteins whose half-life is done, and will break it into peptides and give us the amino acids. So, let us look at the option knowing the function of a proteasome, whether it is protein folding, post-translational modification, protein degradation or protein sorting. The correct option, as I told you, is protein degradation. So, would all proteins go inside the proteasome? No, it will be tagged, the tagged proteins only. What is tagging of a protein? Tagging of a protein is by what is called as a ubiquitin. What is ubiquitous? Ubiquitous is something that is found everywhere or universal. So, ubiquitin is a protein and which will bind to the protein, and these proteins will enter into the proteasome. So, proteasome is a complex, it is a complex where all the faulty proteins go and protein degradation will take place. So, the correct answer is option number C. Proteasome help in protein degradation. Why not the other option? Protein folding do not require proteasome but requires what is called as chaperones or the heat shock proteins. So, the native protein will be folded by the, yes, so native protein will be folded by the chaperone. So, you see this is an unfolded protein, we need to fold it nicely. So, chaperones will help it and it will give us a nice native protein. Okay. So, what about post-translational modification? No, it is a complete different entity because post the protein synthesis after translational, either we add few groups or we remove certain amino acids and make it into an active protein. So, here it is not the case, proteasome is not taking part in post-translational modification. What about protein sorting? What is protein sorting is when the proteins are done with their post-translation modification, it needs to be sorted and it has to be stored and sent to the different parts of the cell. So, protein sorting is done mainly by the organelle Golgi apparatus and not proteasome. So, proteasome function is in protein degradation. Okay. So, this is the structure of the proteasome. So, let us move on to question number 17. In a DNA molecule, the percentage of thiamine residues is 28%. What is the percentage of cytosine? So, let us do a little math over here. Right. So, let us go by the Chargaff's rules of the DNA molecule. What does it state? That the amount of adenine is equal to the amount of thymine and the amount of cytosine is equal to the amount of guanine. Now, what number they have given her here is the amount of thymine, that is 28%. So, if adenine is equal to thymine, that means adenine is also 28. Let us add these up, that is 56%, correct. Now, let us minus from 156, how much do we get? We get 44%, correct. 100 minus 56 is 44. Now, that remaining 44 should be distributed between cytosine and guanine, and now we know cytosine and guanine both amounts are equal. So, it should be 22 and 22, which will give us the remaining 44. So, what is the amount of cytosine? The amount of cytosine is 22%. That is our option number D, 22%. So, there is no reason to look into the other options here because we can do the simple calculation. Okay. Next, a patient presents with peripheral neuropathy, okay, and there is macrocytic anemia. She is treated with 5 milligram of folate, leading to improvement in blood parameters. But what has this done? It has worsened the neurological symptoms. What is the most likely cause? So, the person is having peripheral neuropathy, okay, and macrocytic anemia. Alright. So, first let us see macrocytic anemia. What are the two important causes? One is B12, another is folic acid. Now, if that macrocytic anemia is combined with peripheral neuropathy, you have to remember it is B12 deficiency. Folic acid deficiency would generally be macrocytic anemia, but then if you have neurological symptoms also, then along with macrocytic anemia, then we have to think of B12 deficiency. But what has happened in this case is the person is treated only with folate. So, obviously, the macrocytic picture or the anemia picture has improved. But what has this done to the person? It has worsened the neurological symptoms. So, what is the likely cause? So, I have mentioned to you already B12 is the one causing neurological symptoms. So, the correct answer is option number D. Folate therapy what is given to the person has used up even the available B12 stores. So, let us look into this simple pathway where THFA or tetrahydrofolate, which is the active form of folic acid, and it's taking part in the 1-carbon metabolism. So, conversion of methyl tetrahydrofolate to the active tetrahydrofolate requires vitamin B12. So, if you only give folate, what is going to happen? All this is improved. DNA synthesis is improved. The anemia is also improved. Okay, anemia is improved, but what is going to happen? The B12 will be used up for the conversion of methyl tetrahydrofolate to folate. So, the excess folate what you are giving has used up the stores of B12. So, the neurological symptoms have worsened. So, what would be the ideal way of treating this person is treat them both with B12 as well as folic acid. It should be a combined supplementation. Just giving folic acid will worsen the neurological symptoms. So, the correct answer is folate therapy using the B12 stores has worsened the symptoms. Coming to the 19th question, which vitamin when administered in supraphysiological doses can cause macular edema and macular cyst? So, we know macula, we are talking about the eye. So, this in the macula there is fluid formation. So, fluid filled spaces are also there, that is evidenced by the macular cyst. Which of these medicines are given, vitamin is given in the supraphysiological doses. So, as therapy, vitamin B3 or the nicotinic acid, okay, nicotinic acid is given in the treatment to lower the cholesterol, mainly lower the LDL cholesterol and improve the HDL cholesterol. Okay, nicotinic acid is one of the drug which is given in the treatment of hypercholesterolemia. Now, what if this amount of nicotinamide or niacin is given in a higher amount? That is going to cause edema as a side effect in the eye, macular edema or macular cysts. Okay, so a high therapy, generally about 35 to 50 milligram of nicotinic acid, can also cause flushing, irritability and all the liver or hepatotoxicity. Also the eye, that is macular edema or macular cyst. Why not A, D and E? No. Hypervitaminosis of vitamin A will cause pseudotumor cerebri. Okay, so high amount of vitamin A can cause pseudotumor cerebri, that is evidenced by headaches. Vitamin D also will not cause macular edema or macular cyst. It will most often cause hypercalcemia. Alright, hypercalcemia, because vitamin D is important for calcium metabolism. Vitamin E excess would generally cause hemolytic anemia or bleeding. Mostly the bleeding tendencies when we give vitamin E in excess. So, A, D, E, though being fat soluble vitamins, do cause toxicity but does not cause macular edema and cyst. Niacin, being a water soluble vitamin, when given as therapeutic form, would cause these symptoms. So, coming to the last question, which of the following statements correctly describes the structural organization of proteins? So, how are proteins organized? So, let me write it as primary, secondary, tertiary and quaternary. So, it is like the levels go on increasing from simple to complex. So, what is primary structure? So, if you look into the diagram, we understand primary structure is when you have individual amino acids linking together by the bond what is called as a peptide bond. This is the simplest of the organization. A little more amino acids we have, it becomes a higher level of organization. It twists itself into alpha helix, beta sheet, and the bond from peptide bond changes to hydrogen bond. So, secondary level will have hydrogen bonds. Tertiary level, again the polypeptide becomes a little more twisted, and yes, we get a polypeptide which is bound mainly by the disulfide bridges or the sulfur bonds. Okay. Quaternary, multiple polypeptides organize itself in forming a protein. Yes, so that's the quaternary structure. Now, what are the options here which is correct? Tertiary structure is three-dimensional. So, let's look at it. Is it three-dimensional? Yes, tertiary structure is three-dimensional. Primary, secondary and tertiary structures are destroyed by denaturation. This is incorrect because it is secondary, tertiary, quaternary structure which are destroyed by denaturation. The primary structure is retained in denaturation. Secondary structure is stabilized by disulfide bonds. No, secondary structure is stabilized by hydrogen bonds. Tertiary structure is stabilized by disulfide bonds. Secondary and tertiary structures depend upon amino acid sequence. Partly correct, but fully incorrect because completely doesn't depend on the amino acid sequence, it depends on the bonds as well. So, what is the correct option? Out of these four, the closest and the best option we have here is tertiary structure is three-dimensional. Easy to remember, tertiary means 3, which is a 3D. Okay, tertiary structure is three-dimensional. So, here we have finished all our 20 questions. So, thank you for being with me in this session of PYQ in biochemistry.